ယနေ့ကျင်းပပြုလုပ်တဲ့ Hepatitis B Management Guidance Development Launching Meeting ကိုတက်ရောက်လာကြသောအသေးရောဂါကုပါမောက္ခဆရာကြီးဆရာမကြီးများနဲ့အထူးကုဆရာဝန်ကြီးများအားလုံးကိုကျေးဇူးအထူးတင်ရှိကြောင်းဦးစွာပထမပြောကြားချင်ပါတယ်။ယနေ့ Hepatitis B Management Guidance Development ပွဲကိုအောက်ပါအစီအစဉ်များနဲ့ကျင်းပပြုလုပ်သွားမှာဖြစ်ပါတယ်။အစီအစဉ်1အခမ်းအနားဖွင့်လှစ်ကြောင်းကြေညာခြင်းအစီအစဉ်2 Professor ဆရာကြီးခင်မောင်ဝင်းမှChairman of Yangon GI Liver Center, Senior Patron of GI Liver Foundation မြန်မာမှာအဖွင့်မှာစကားပြောကြားခြင်းအစီအစဉ်3ဆရာကြီး Professor ကျော်စိုးထွန်း President of GI Liver Foundation မြန်မာမှာကြိုဆိုနှုတ်ဆက်စကားပြောကြားခြင်းအစီအစဉ်4 Viatrix Mylan Company မှာ Head of Commercial Operation Asia Alliance ဒေါက်တာတာရကာပွန်ချီပန်ဒရာမှာကျေးဇူးတင်နှုတ်ခွန်းဆက်စကားပြောကြားခြင်းအစီအစဉ်5 Process of Guidance Development ကိုဆရာကြီး Professor ခင်မောင်ဝင်းမှပြောကြားခြင်းအစီအစဉ်6ဆရာကြီး Professor ကျော်စိုးထွန်းမှဏီကုန်းချုပ်အမှာစကားပြောကြားခြင်းဖြစ်ပြီးတော့စီစဉ်9ကတော့အခမ်းအနားပြီးဆုံးကြောင်းကြေညာခြင်းတို့ဖြစ်ပါတယ်အစီအစဉ်1အရ Hepatitis B Management Guidance Development Launching Meeting စတင်ကြောင်းကြေညာအပ်ပါတယ်ရှင်စီဇန်2အရာဆရာကြီး Professor ခင်မောင်ဝင်းမှအဖွင့်အမှာစကားပြောကြားပေးပါရန်လေးစားစွာဖိတ်ကြားအပ်ပါတယ်ရှင်
A very good evening, distinguished guests, especially from Sri Lanka, Mr. Banyatarga and Mr. Rubin, and Professor Dansei, and Professor Myunyo, Myanmar Red Cross Chairman, and Professor Kimaoe, MMC Chairman, Professor Eong, President of the Myanmar Medical Association, and Dr. Kim Byung-ji, President, Chairman of the Liver Foundation, Myanmar Liver Foundation, and all other professors, my colleagues. Today is a great day for us, for our GI Liver Foundation, Myanmar, because we have achieved a very good, excellent, auspicious guideline in our hand. The guideline in our hands of Mr. Deo Labiu. Like Mo Zedong's red book, this is the guideline. The guideline, we are so proud for, not only for our society, it's only for our hepatology society as well as for the country. In this region, recent guideline, hepatitis B guideline, Myanmar is the only country which can develop the guideline. Not only that, we have previously had ACC guidelines as well. In fact, I will later explain why we do not call guideline, why we call guidance. That I will explain later for those who has not attended our previous meetings. This will never happen without the support of the Mylan, and particularly Mr. Banyatarka and Sensei and Mr. Rubin, full support, unlimited educational support. For this, we appreciate. I would like to express my sincere thanks to Mylan and all those colleagues. And this guideline, we try to cover as much as we can to be able to cater to the low level, district level general practitioners, as well as we're trying to, at the same time, we want to educate the physician levels as well. So it is a product of our hard working of our writers group and the chairs, and particularly I'll have to express Professor Josudun, whose enthusiasm and energy that has driven all the writers for the production of this. So we are with this guideline, we will be quite satisfied. We'll stop and sit and do nothing. No. We'll proceed to the hepatitis C, but I have to apologize, Mylan, not this year. 2024, we are so busy. So we'll start our hepatitis C guideline development next year, 2025, starting from February or March. We'll begin that with the new developments in the American labor meeting and whatever has come up, and we will include all the new findings as well as the practical points for the general practitioners in general. So allow us to develop the hepatitis C guideline. May you note it down. 2025 February will start. This year our hands are full. With this, I would like to conclude my opening speech. Again, thanks for the GLS Myanmar, Professor Tanai, also for your, auspicious presence here. And we will combine GLS and GLF combined meeting in December, which will be very, esteemed and making all the neighboring countries envy us. And Mr. Tarka, I want you to invite your participants from Sri Lanka in December 13, 14, 15, all the top people in the field of NAFLD, in the field of MESLD, in the field of cirrhosis, in the field of world-renowned, not the local speakers, and your participants from Sri Lanka will benefit a lot. So I would like to request Mylan to support those people, at least 5 or 6 people, to attend our meeting here. And beautiful evening. Let's enjoy the launching of the our guideline. And my people ask me, will there be a Q&A session? No. We have gone through that Q&A, everything finished. The product's here. There should be no Q&A we have. So I think the Rider Cruise Chief Coordinator, Sam Myeong-shan, will coordinate for the section writers to present. And before that, I will start with my guidance development explanation. Thank you very much.
ဝင်းမှာစကားပြောကြပြပါတော့ဆရာကြီး Professor ခင်မောင်ဝင်းကိုကျေးဇူးတင်ပါတယ်။ Season 3ရဆရာကြီး Professor ကျော်စိုးထွန်းမှာကြိုဆိုနှုတ်ခွန်းဆက်စကားပြောကြပေးပါရန်လေးစားစွာဖိတ်ကြားအပ်ပါတယ်။
Hello, welcome everybody. It's a very good evening. Actually, we can say it's a very pleasant day in the midst of the typhoons. This day is a lovely day and sunny also. And I'm very glad to see all our colleagues from our policymakers plus general primary physicians taking care of hepatitis B at the root level, and all the specialties so that you can criticize this, our hepatitis B guidance. First, I would like to thank Mr. Ruben, Mr. Taraka, Sinseme, and Mylan for having an idea to make a guidance on hepatitis B. Because as you all know, this is a time we need to develop this kind of guidance. If you look at the burden of hepatitis B, mostly nearly all the diseases, including oncology, are on the downward trend, except our hepatitis B. So there are a lot of problems, we can call it. To highlight it, 1 million of people is dying a year from chronic hepatitis B and its complications. That means it is 2 people in a minute. So we are losing now many people because of this chronic hepatitis B, despite we are having a vaccination to protect hepatitis B, and then very wonderful drugs like tenofovir and entecavir. Although we can cure it, we can suppress it. Despite that, we are losing the battle. There are many problems of this chronic hepatitis B. Among the 25 million to 50 million infected by chronic hepatitis B, only 8% is diagnosis, and among that 8, only 1% has been actively treated. So, and 20 to 30% has gone into cirrhosis and HCC and death, as I've mentioned earlier. There's a gap in hepatitis B compared to HIV. HIV, the prevalence is 36.9 million. 27 million is diagnosis and 21 million has been treated. So most of the HIV case has been diagnosed and treated. In HCV, 70 million prevalence, and then diagnosis is 14, much less than HIV, but now the treatment is only 1 million has been treated. But still, we had a cure in hepatitis C, like very good molecules, and like the product of Mylan. For hepatitis B, out of 292 millions of hepatitis B, only 28 millions has been diagnosed and only 4.8 millions has been treated. There's a wide gap between the prevalence, the diagnosis, and treatment. So why can't we copy the success of HIV and HCV in HPV? Now, because of the COVID, thanks to COVID, the medical technology is advancing, and then we had a lot of point-of-care testing, including this point-of-care test, which can relieve the hospital care and big laboratory diagnosis. And there are a lot of other molecular signatures we can detect it, like siRNA, and then core antigen and virions, everything. So they are the met needs and unmet needs in chronic hepatitis B. In hepatitis B, yes, the drugs are very good. We can do a long-term suppression. We can have a fibrous regression, and we can reduce HCC risks. But we can't eliminate HCC risks, and we can't eliminate progressing to cirrhosis. And then with the long-term management, there are a possibility of side effects, although there is, because of this TTF and TAF and entecavir, they have a little drug resistance. But still, we need a long way to go with these nucleoside analogs. This, most of this untreated chronic hepatitis B has a tremendous HCC risks. What I mean untreated is not that I'm diagnosed. We are diagnosed hepatitis B, but we can't treat hepatitis B all because of the restraints of the previous guidelines. I will tell you later. So these are the current guidelines. The latest is 2017. ASLD, the latest is 2018, APASL 2016. The Chinese is 2022. And WHO has launched its hepatitis guideline in March 2024. Our speaker says we have referenced more on this WHO guidelines. In these previous guidelines, there is a big gray zones where, although we have diagnosis, we can't treat the patient because of strict ALT level, strict HBDNA level, and maybe biopsy or invasive investigations. Now we must only treat hepatitis B only when the viral load is 20,000 or the ELD must be raised more than 2 ULN, or the age must be 30 years or something so and so. These are they are what you call restrictions in the treatment of chronic hepatitis B. And as I have already mentioned that chronic hepatitis B can lead to cirrhosis and ACC. And then we are losing a lot of what call important cases we have gathered. So this is a cure of hepatitis B. It will be elaborated by the speakers concerned. And now we have a lot of tools for hepatitis B elimination in the pipeline. Also the immune modulation drugs, and then what you call therapeutic vaccines, and so forth and so on. These are the drugs on the pipeline. And so what I want to say is that because this guidance, it is really in need at this time. And thanks, Mylan, for sponsoring it. Thanks, Siaji, for your leadership. And thanks for all the members of GI Liver Foundation. They have put in a tremendous effort in writing their part of hepatitis B guidance. So after this, you can hear the presentation of the concerned speakers, and their lovely job. And I hope you can criticize it in the practical level. And as Yaji has mentioned, we are going to have a 7th international meeting on GI and liver on the December 14th and 15th at Wyndham Hotel. So we have 26 world top hepatologists from West and East, and 8 from gastroenterology. You can see the name of like a big name like Dr. Reddy's, Abraham Shaket, Arun Sanyal, Robert Gish, and a lot. And I've been coming from the East, Southeast Asia also, from Singapore, Hong Kong, Thailand, and India. So this is the schedules. We will hand it out to you later. So without much ado with that, I would like to end my section. Warmly welcome everybody, and please enjoy the latest hepatitis guidance by GLF, and I hope you will enjoy it. Thank you very much.
လူလူနှုတ်ခွန်းဆက်စကားပြောကြားပေးပါတော့ဆရာကြီး Professor ကျော်စိုးထွန်းကိုကျေးဇူးတင်ပါတယ်။ Season 4 ရ May I kindly invite Dr. Taraka to the stage to deliver thank you note.
It's a great pleasure to be here. Good evening, everybody. Good evening, ladies and gentlemen. First of all, I cannot forget this name in my life. CRG, Professor King Marvin. I know him 7 years back when I first stepped into this country as a commercial head. So thank you so much. I think with the help of Professor Sotutung and all the other medical fraternities in this country, something which brought to a reality. So I should say thank you so much. Yes, we have supported commercially and financially, and we arrange everything, but nothing like something come out which is very important one to the society. Sir was single-handedly say that, Taraka, we have to do this thing because this is one of the things which is pending. CRG, I think we done it right after 4-5 sessions. So all the people, all the heads and all the arms which is there, I should thank to DKSh, Ruben and the team, and especially Tintin. Where is Marcin, the Iron Lady? Marcin? Oh, she's taking some photos, right? I used to tell her, like, you are the biggest pillar behind in this, the hepatitis business in, hepatitis development in Myanmar. So thank you very much. And the marketing people like Dr. Sumyat and Dr. Kin, and all the people who supported to get this reality done. I won't take much time. Thank you, Seaji. Thank you all being here. And we definitely, as you said, Seaji, we will definitely support in the December meeting. I'm taking care of nearly around 18 countries under me. So at least I will make sure that all the Southeast part, I will make sure that good participation from countries which I'm handling. Thank you so much. Good evening to you.
Thank you, Mr. Taraka, for delivering. Thank you. No, အစီအစဉ်ကအရာ process of guidance development ကိုပြောကြားပေးပါရန်ဆရာကြီး Professor ခင်မောင်ဝင်းကိုလေးစားစွာဖိတ်ကြားအပ်ပါတယ်ရှင်။
Oh, yeah. For those who are not familiar with our term, the guidance, allow me to briefly explain what is the guidance and what is the guidelines. If you look at the guidelines produced from the European side, these are UC guidelines. But if you look at LA, Latin America, or the America, you will see the terms guidance. So for us, we adopt the ASLE policy on the naming our booklet as guidance. So ASLE policy, there are clinical practice guidelines, all the guidances, all the position papers. So for the guidelines, there should be grading of the recommendations, systematic reviews, data-supported recommendations. These are essential. And you need an expert who will be teaching those involved in the writing group for the systematic reviews. So practice guideline development is very complex. The PICO, population intervention, comparative outcomes, a lot of things are necessary. But in fact, what we are doing here in Myanmar is we are just a group of writers look for the literature, we go through the literature, we write the recommendations and compile the references and put up to the committee. That is the guidance. That is not the guidelines. So these are the, just for completeness, I have presented this for many times. So again, ASLE policy and procedures of the practice guidelines committee will identify the subjects and the writing groups are formed and the review of the published guidelines. So the Myanmar, we take the ASLE policy and we use practice guidances, not the guidelines. First, we form the practice guidance committee comprising the chairs. The chairs will be University of Medicine 1, University of Medicine 2, University of the Medicine Mandalay, and the DSMA, and the Yangon GI and Elizabeth Center. From these, we have nominated 5 chairs, maybe some are more, and then the writing groups are formed from those representative institutions. To all intents and purposes, the practice guidance committee for any guidance, not only the hepatitis B, ACC, MSLD, forthcoming hepatitis C, we chairs, reviewers are myself, Professor Chosotun, Professor Tanatun from Mandalay, and Professor Wunsi, Professor Nanaitun. And our responsibility is we choose the subject. We identify the topics of the subject. We assign topics for the writers. We review drafts and make comments. So this applies to any subject. So the writing groups, Dr. Myeong Shan is the writer as well as chief coordinator of the writing groups. He will try to organize a draft, prepare the combined document. The chair will be Professor Chosotun, and from Mandalay, Professor Nanke Diwin, and Professor Tanatun will be chair. From the Meiji Cho, then the Professor Winswee, Dr. Nyemonyu, Professor Nanaitun. And in the UM1, Professor Dr. Meiji Cho plus Professor Angku Cho, assistant lecturer, lecturer, assistant professor. Professor Angku Cho and Meiji Cho. Then Nyemonyu and Professor Nanaitun. And from my YGLC group, Dr. Online Boa, Dr. Siu Sewin, and myself. So this is by appointing this kind of chairs and writers are very systematic, and each group has to take responsibility for writing their assigned subjects, topics. So the framework will be based on the ASLE chronic group. So I have to repeat again, the guidelines or the guidance, the ASLE, according to the ASLE definition, the guidelines are very complicated. You need to have a systematic review. You need to have the grading of the references. You need to have the specially trained person for teaching the writing group about this systematic grading of the references, which we cannot. What we are doing, we assign the topics, and all the writers will go through the literature. We write, with the compilation of the references and the review, we review. So To come up with this book, we have to walk a lot. All the writers, they write, then plenary session, we discuss, the next second draft, third draft, finally this final book and the guidance we are now launching, and this is the end result. So if somebody asks you, why not the guidelines, why the guidance? Because we adopt ASLD policy. ASLD guide, according to ASLD guidelines, you need a very systematic upgrading of the references, which we cannot do. So we are going through references, so we are guidance, our guidance. How do we manage? We, depending upon the 5 institutions, we have named the writers and the chief coordinator of the writers and the chairs, and each writer will write the draft, which the coordinator will combine, and at the plenary session, our valuable comments, not every single comments. The valuable comments are making sure that in the next meeting, our comments are included in the draft. So first draft, second draft, third draft, and finally we are here with the final guidance book. That's how we work it. This is much easier. With this, we have easily developed the ACC guideline. We're going to produce the cirrhosis guideline. We are going to produce the MASLD guideline. MASLD guideline has never been developed by anybody else in the neighboring country. And there's a great controversy, whereas metabolic dysfunction associated liver disease, MASLD or MFLD, metabolic associated fatty liver disease. The Americans said, you Asian, you upper cell use MFLD, metabolic associated fatty liver disease. Fatty means discrimination. According to the US human rights concept, you cannot use the term fatty. You are naming a person fatty, so discard it. It should be metabolic steatotic liver disease, not the fatty liver, SLD. Steatotic, no discrimination, and the doctors will easily understand. So we are the first country in this region to adopt the MASLD. So MASLD guidance will come out within 1 month and very soon. And we are, our society, GLF, our GLF Foundation, very proud to be able to do a series of guidances and mark it in your calendar. Next year, 2025 February, we'll start the hepatitis C guidance. Thank you very much. Thank you, everybody. Thank you, the writer, chair, everybody. Thank you very much.
Process of guidance development ကိုပြောကြားပေးပါတော့ဆရာကြီး Professor ခင်မောင်ဝင်းကိုကျေးဇူးတင်ပါတယ်စီစဉ်6အရာ Writing Group Coordinator ဆရာဒေါက်တာမင်းအောင်ရှမ်းမှ Introductory Speech ကိုပြောကြားပေးပါရန်လေးစားစွာဖိတ်ကြားအပ်ပါတယ်ရှင်
Good evening, CIE professors, ladies and gentlemen. I will present briefly about the processing of the clinical practice guidance recommendation for the hepatitis B infection. We previously produced the hepatitis B guideline in 2013. This is updated for the guidance for the hepatitis B management. We can produced the hepatitis C guideline in 2014 and updated in 2017. So next year, we update for the updated hepatitis C guideline in 2025. And we already produced the cirrhosis guideline in 2017. So ACC guidance already launched on the 4 May 2024. And now today is the clinical practice guided recommendation for chronic hepatitis B infection. And we will launch on MESD, metabolic dysfunction associated cirrhotic liver disease. We will launch on the 2nd November 2024, and suicidal liver guideline guidance will be launched on 30th November 2024. As CIE already mentioned about the chairs and reviewer and the writing groups. These are the chairs and reviewer for the development of the clinical practice guidance for the HPV infection. This is the process to produce the guidance. First of all, we review the literature and condense the literature sets for each session. A draft of each session with the bibliography is presented to the chairs and reviewer, and the writing group leaders create a combined document that is reviewed by chairs and all members of the writing group, which involved into the draft one. Draft one is presented to all hepatologists for comments developing draft 2. Draft 2 is presented to all hepatologists and gastroenterologists for comments leading to draft 3. And draft 3 is open to all hepatologists, gastroenterologists, and also consulted from the other relevant specialty, general physician and GB developing draft 4. And now draft 4 is to be reviewed and modified as necessary by chairs and writing group, and final copy is produced for the publication today. I would like to present about the preventing, diagnosis, and management of chronic hepatitis B infection, which include the introduction, epidemiology of chronic hepatitis B in Myanmar, screening, counseling, and prevention of hepatitis B will be present me. Associate Professor Mijijo will present about the definition and phases of chronic hepatitis B, selected diagnosis tests used in management of chronic hepatitis B, and screening for ACC. Dr. Onlewan will be present treatment of chronic hepatitis B. This is the main topic of today announcement for the chronic hepatitis B guidance. Monitoring and follow-up of the patient during antiviral therapy. And Dr. Muzama will present about the management of chronic hepatitis B in special population, including the acute hepatitis B infection, person with persistent low-level viremia on nucleotide analog therapy, and renal and bone disease in person on any treatment. Finally, Dr. Nyemu will present about the management of chronic hepatitis B in pregnancy, and treatment of chronic hepatitis B in children and adolescents, and treatment of chronic hepatitis B in co-infected patients. All the speakers will present about the only key points and recommendations for the management of chronic HPV infection. First of all, I would like to present about the screening, counseling, and prevention of hepatitis B. For the recommendation for screening, screening is recommended in all persons, especially in high-risk groups, by using HBs antigen testing. This table shows the group at high risk for the HPV infection: all persons born in Myanmar, a person with chronic liver disease, individual with elevated ALD or AST, HCV or HIV infected individual, family members, household contacts, set partners of the person infected with chronic HPV, infant born to HBs antigen positive mothers, immunosuppressive or cancer chemotherapy on treatment, and injection drug user with needle sharing, person who receive MC injection, health care and public safety workers, men who have set with men, and routine screening to all pregnant women, dialysis patient, donors of blood, plasma, organs, tissue, or semen, image of the correctional facility, and travelers. Next one is a screening for anti-HPC to determine prior exposure is not routinely recommended, but is an important test in patients who are about to undergo chemotherapies or other immunosuppressive therapies and in organ donors. Screening should be linked to appropriate counseling and referral for further care, including clinical evaluation, need for the treatment, and vaccination if found to be negative for HPV infection. HPS antigen positive. Next one is a recommendation for the counseling of the person who are HPS antigen positive. Recommendation are the HPS antigen positive person should be counseled regarding prevention of transmission of HPV to others according to table. And these are the person who are HPS antigen positive should have household and sexual contact vaccinated, use barrier protection during sexual intercourse, not share toothbrushes, razors, not share injection equipment, glucose testing equipment, cover open case or scratch, clean blood spray with branch each solution, not donate blood organs or sperm, can participate in all activity, including contact sports, can share food and kiss others. Next one is the estimate of alcohol is recommended in chronic HPV infected person. Optimization of body weight and treatment of metabolic complication, including control of diabetes and dyslipidemia, are recommended to prevent concurrent development of metabolic syndrome and fatty liver. Healthcare workers and students who are HPS antigen positive should not be excluded from training or practice, but they should not perform exposure-prone procedures if their serum HPV DNA level exceeds 1,000 IU per ml. But they can perform exposure-prone procedure if their HPV DNA level is reduced or maintained below 1,000 IU per ml or on treatment. Chronic HPV infected subjects should not be discriminated and stigmatized in the society or in their workplace. HPV infected children should not be isolated in the educational and social environment. Sexual and household contacts of the chronic HPV infected person who are negative for HPV seromarker should receive hepatitis B vaccination. Next one is recommendations for counseling of HPS antigen positive women in pregnancy. Women identified as HPS antigen positive during pregnancy should be linked to care for additional testing and determination of need for antiviral therapy. Women who meet standard indication for HPV therapy should be treated. Women who meet prophylaxis indication to prevent mother-to-child transmission should be treated in the second trimester. HPV infected pregnant women with cirrhosis should be managed in high risk and treated with TDF to prevent decompensation. TDF is safe in pregnancy. Breastfeeding is not prohibited while the mother is on antiviral therapy or infants who receive active passive immunization. Newborns of HPV infected mothers should receive HPIG and HPV vaccine within 12 hours of delivery and complete the recommended vaccination series according to EPI program. Infants of HPS antigen positive mothers should undergo post-vaccination testing at 9 to 15 months of age. Sexual partners of women identified as HPV infected during pregnancy should be assessed for HPV infection or immunity and receive HPV vaccine if appropriate. This is an expanded program on immunization in Myanmar. Within 24 hours, those to the week 8, week 16, week 24, and 1.5 years. Recommendations for prevention. Prevention of HPV infection by immunization is the best way to eliminate HPV-related diseases. All unvaccinated persons, especially in high-risk cross-transmission, shown in the table 1, should be targeted for catch-up vaccination as well as the other preventive strategies. Preventive strategies are the avoid the routes of transmission for HPV infection. Prevention of HPV infection. All vaccinated and vaccinated persons, especially in high risk of transmission, table 1 should be targeted for catch-up vaccination as well as other preventive strategy. And all HPS antigen negative screening persons, including adults 60 and older who are at high risk for infection, should be vaccinated. All pregnant women should be tested for HPS antigen during the prenatal visits in the first trimester of their pregnancy, and all HPS antigen negative pregnant women should be vaccinated. Vaccination against HPV is both safe and efficacious during pregnancy. HPV monovalent vaccine should be given as a 3-dose series at 0, 1, and 6 months, or an alternative 4-dose schedule at 0, 1, 2, and 12 months. And as required as table 4, all doses of the vaccines are required in in order to be fully protected against hepatitis B. This table shows the HPV vaccine schedule for Myanmar. Standard region is 016, and alternative region is 012 and 12. Vaccination against HPV is both safe and efficacious during pregnancy. That dose HPV monovalent vaccine within 24 hours is recommended for all infants, followed by the subsequent 3 or 4 doses of HPV pentavalent vaccine, according to a expanded program of immunization policy in Myanmar. 10 microgram dose 0.5 ml is recommended for use in infants, regardless of the birth weight, and children up to 18 years of age. 20 microgram dose 1 ml is recommended for use in more than 18 years of age and should be increased to 40 microgram 2 ml for people living with HIV or hemodialysis or immunocompromised patients, including those with cirrhosis of liver. All infants of HBs antigen positive mother is recommended to receive their first dose of hepatitis B vaccine as soon as possible after birth, preferably within 12 hours, and HBIG should be given simultaneously at different sites intramuscularly if available. The dose of HBIG is 0.5 ml, 100 IU, and the doses of the HPV vaccine for newborn is 10 micrograms, 0.5 ml, regardless of the body weight. The birth dose vaccine must be followed by 3 or 4 doses of hepatitis B vaccine to complete the primary series in order to achieve maximal efficacy for prevention of mother-to-child transmission. HBs antibody quantity is not routinely recommended to test after HPV vaccination. But healthcare workers, sexual partners of persons with chronic HPV infection, chronic hemodialysis patient, and immunocompromised person, including those with HIV, should be tested for their response to the vaccination at 1 to 2 months after the last dose of vaccine. Furthermore, annual testing of chronic hepatitis patient in vaccine responder is recommended, given that immunity wanes rapidly in these individuals who are at high risk of continued exposure to HPV. For non-responder to the initial vaccine series, a rapid 3-dose vaccination series at 0.16 months is recommended. Booster doses or revaccination are not recommended in immunocompetent individuals if the primary vaccination series is completed, except if any HBs antigen remain less than 10 after initial vaccination of infants born to HBs antigen positive mothers, in healthcare workers, hemodialysis patients, and other individuals who are immunocompromised. HPV vaccination with or without HBIG within 24 hours of exposure is recommended for post-exposure immunoprophylaxis of and immunized individuals who have percutaneous mucosal or sexual exposure to HBs antigen positive sources. This table shows the post-exposure management, and mainly is the response and no after complete series or the unvaccinated persons should be received HBIG1 dose and initiate the revaccination of HPV vaccine. And thank you very much for your kind attention. I will call Professor E.B. Mijijo to the stage to present the selected diagnosis test used in management of chronic hepatitis B and screening for ACC.
Good evening, all the distinguished guests, my teachers and my colleagues. Today, I would like to discuss about our assignment done by our group, guided by Professor Wen Sui from University of Medicine 1. Our assigned topics are as follows: definition and phases of chronic hepatitis B, selected diagnostic tests used in the management of chronic hepatitis B, and screening for ACC. As we all know, the definition of chronic hepatitis B infection is a simple one: a person who has HBs antigen positive for more than 6 months, we call it chronic hepatitis B infection. And I would like to highlight this table. These are the phases of chronic HPV infection, and there are altogether 5 phases. The terminology The old terminology was highlighted in the last line, and the new terminology was highlighted in the upper column. As in the diagram, we call the E positive chronic infection. Initially, we called it immune tolerance. Chronic E positive chronic hepatitis B, we have called it immune reactive E positive. And chronic infection, E negative chronic infection, initially we called it inactive carrier, and E negative chronic hepatitis, initially we have term immune active or E negative disease. And occult B infection is the HBs antigen positive people with the low detectable HBV DNA. And there are some distinction points, as antigen is usually high in the E positive patient and low in E negative patients. And HBV DNA is also high in E positive and low in the E negative. Whereas in the occult V, there is a low or non-detectable HBV DNA level. As the terminology, chronic hepatitis cases, ALD is usually elevated, and whereas in others phases, usually upper limit or normal, around upper limit or normal. As for the liver disease severity, there is usually minimal necroinflammation in chronic infection phases and occult B infection. But in case of chronic hepatitis, there is moderate to severe inflammation. And then the next topic is the serological test for the management of chronic hepatitis B. As we all familiar with the blood tests done in the chronic hepatitis B, like liver function test, the alpha fetoprotein, renal function test, and the CpO2. We also do the ultrasound to exclude the fibrosis or cirrhosis. And here I would like to highlight the some tests. This table showing the serological markers of HBV infection. If the serological markers and BDNA are negative, we can call it never infected. But in some cases, HBs antigen P positive up to 18 days after vaccination. And in case of early acute infection, S antigen and BDNA level, BDNA are detectable. Whereas in acute infection, all the serological markers like S antigen, HPC co-antibody, co-antibody, and HBB DNA is detectable in acute infection. Whereas in acute resolving infection, S antigen become positive, others are S antigen become negative, and all other serological markers still positive. If a person have recovered from past infection, HBC co-antibody and anti-HBs is positive, and all other serological markers are negative. In case of chronic infection, as we usually familiar, S antigen, anti-HBC co-antibody, and HBV DNA are detectable. Sometimes we can encounter the like anti-HPC positive. It may be the test error, like a false positive, or the person have past infection. If the anti-HBs antigen, anti-HBs alone positive, this is due to the immune, due to vaccination. And usually, if the anti-HBs titer is more than or equal 10 IU per milli IU per ml, it is enough, and it is a vaccine responder. The next I would like to highlight is the NID, non-invasive test. We initially nowadays we have a NID tests are the popular in the management of chronic liver disease. And the NID are like the APRI score, FIFO score, and the transient elastography. For the APRI and FIFO score, we can easily calculate it as in the guidance books. We can calculate it by using the ALT, AST, age, and platelet count, and we can define the whether the person has significant fibrosis or cirrhosis. Here we the APRI cutoff, lower cutoff is the for significant fibrosis is that means the more than or equal fibrosis staging F2 is APRI cutoff 0.5. And for the cirrhosis, in patient with chronic hepatitis B infection, APRI cutoff for cirrhosis is 1.0. Whereas in the transient elastography, liver, we can measure in the we can measure liver stiffness measurements, and if LSM is more than 7 kPa, we can define the significant fibrosis. That means the F2, and if the LSM is 12.5 kPa, more than or equal 12.5 kPa, we can call it cirrhosis. And this table is showing the some tests we would like to highlight. We usually done the hepatitis B DNA testing for treatment decision about the initiation and evaluation of patient response to antiviral. And nowadays, HBs antigen quantitative assay, we call HBsAg assay is useful, and it can predict the outcome of patient receiving the nucleotide analog as well as back interferon therapy. And we can draw the selected candidate to withhold the therapy from therapy, considering together with the hepatitis B DNA, and therefore it should be checked every 6 to 12 months. And what about the hepatitis B genotyping? Here we have a genotype is genotype C, and for the interferon, pegylated interferon therapy, genotype A and B have a high chance of S antigen and E antigen clearance. But in our country, genotype C is very common, and it is the highest risk for the ACC development. We not usually done the genotyping testing here. For the antiviral resistant, we not usually done the viral resistant testing, but in cases of persistent viremia or nucleotide analog therapy or those with virological breakthrough, we should done the viral resistant testing, because here we are using the nucleotide analog with high genetic variant like tenofovir and the anti-KVR and tenofovir alafenamide. Finally, we have some recommendation for screening for ACC. This is the same in the ACC guideline. And the ultrasound and AFB you should be done every 6 months in patient with compensated COL and patient with chronic hepatitis B infection who have additional risk factor like obesity, diabetes, NAFLD, and alcohol, and the smoking like that. But in patient with decompensated cirrhosis, we usually done the surveillance very frequently, like every 3 to 4 months. This is the end of my presentation, and thank you. The next topics about the treatment of chronic hepatitis B and monitoring and follow-up of patient during antiviral therapy will be discussed by the Dr. Online Bois. May I call upon Dr. Online Bois for your presentation.
မောင်ခါဆရာကြီးဆရာမအားလုံးလည်းကွာဆရာမအားလုံးမင်္ဂလာပါဒါတော့ကျွန်တော်တို့ရဲ့ဒီနေ့ assign topic ဖြစ်ပါတယ်အဲ့တော့ကျွန်တော်ဒီ recommendation ကိုမတွားခင်ပါပါเนาะကျွန်တော်တို့ဘာကြောင့်ဒီ recommendation တွေလုပ်ရတယ်ဆိုရဲ background data လေးကိုအနေငယ် present လုပ်ချင်ပါတယ်ဒါတော့ခုနကဆရာကြီးဦးကျော်စောလွန်ပြောသားလို့ပဲပါเนาะကျွန်တော်တို့ hepatitis B ကို treatment လုပ်တဲ့အခါမှာကျွန်တော်အပါဆဲ EASL AS တွေရှိတယ်ဒါတွေကလည်းကျွန်တော်တို့ကဒါဟို diverse ဖြစ်တယ်ပေါ့နော်ဥပမာ hepatitis B DNA cut off တွေကမတူ ALD AST cut off တွေကမတူဘူးပေါ့နော်ယောက်ျားမိန်းမကွာတယ်အသက်အရွယ်ကွာတယ်ပေါ့အဲ့တော့ကျွန်တော်တို့ကဘယ် guideline ကို follow လုပ်ရမလဲဆိုတဲ့ပြဿနာကြီးရှိတယ်ပေါ့နော်အဲ့တော့ဒီတနည်းအားဖြင့်ဒီ guideline တွေကိုဟိုလုပ်တဲ့ခါမှာလည်းဒါ follow up လုပ်တဲ့ခါမှာလည်းဒါတနည်းအားဖြင့်ပြောမယ်ဆိုရင် restrict ဖြစ်တယ်ပေါ့နော်အဲ့တော့နောက်ဆုံးကျွန်တော်တို့ WHO ရဲ့2024 report မှာဒါကျွန်တော်တို့ only 30% of the chronic hepatitis B infection has been diagnosed and only 3% has been treated with the current international guideline at the end of the 2022 no? Because of due to the complexity and restriction of the clinical practice guideline အဲ့တော့ကျွန်တော်တို့ရဲ့ WHO target ကိုကြည့်တဲ့အခါမှာကျွန်တော်တို့ကဒီ2030မှာကျွန်တော် WHO က hepatitis ကို elimination လုပ်ဖို့ဒါ target တွေရှိပါတယ်ပေါ့နော် new infection ကတော့ဒါ 90% reduction ဖြစ်ရမယ်hepatitis related mortality ကတော့ဒါ 65% ကြီးကျသွားပြီပေါ့နော်အဲကျွန်တော် treatment ကိုကြည့်လိုက်တဲ့အခါမှာလည်းဒါ2030မှာဒါ 80% treatment coverage ရှိရမယ်ဆိုပြီးတော့ပြောပါတယ်အဲ့တော့ခုနကကျွန်တော်တို့ဒီ2023 report မှာ only 8% ပဲဒါ treatment ရထားတဲ့ population တွေရှိပါတယ်ဒါကြောင့်မို့လို့ we need the expanded treatment ဒီ guideline ပေါ့နော် treatment eligibility ကိုကျွန်တော် expand လုပ်ရမယ်ဆိုတော့ဒါကျွန်တော်တို့ပြောလာကြတယ်ပေါ့နော်အဲ့တော့နောက်ဆုံးဒီ Korean ဟို report တစ်ခုမှလည်းကျွန်တော်တို့ကဒီ guideline 3ခုရှင်းလိုက်တဲ့အခါမှာဒီ HCC patient တွေကိုကျွန်တော်တို့ကြည့်လိုက်တဲ့အခါမှာ outside the treatment guideline ဥပမာအပါဆယ်ရဲ့ 64% က outside treatment ဒီ guideline ကဒါ HCC development ကဒါများတယ်ပေါ့နော်အဲ့တော့ EASL ကတော့ဒါ 33% ပဲရှိတယ်ပေါ့နော်အဲ့တော့တနည်းအားဖြင့်ပြောမယ်ကျွန်တော်အပါဆယ်ရဲ့ဒီ treatment guideline ကိုကြည့်မယ်ဆိုရင်တိတ်ပြီးတော့ restrict ဖြစ်လို့ ਨੇ အဲ့တော့သူ့ရဲ့ guideline ကိုလုပ်မယ်ဟို follow လုပ်မယ်ဆိုရင်ဒါ HCC risk တွေကtreatment ကုရတဲ့ကုသတဲ့ဒါ treatment မရတဲ့လူတွေလို့ဒါကျွန်တော်တို့ကပြောလို့ရတယ်ပေါ့နော်အဲ့တော့နောက်တစ်ခုကတော့ကျွန်တော်တို့ကခုနဟိုစမတို့မေဂျီကျော်ပြောရတဲ့မှာလည်းပါတယ်ပေါ့နော်အဲ့တော့ immune active phase တွေနောက် immune inactive phase တွေကြားထဲမှာလည်းကျွန်တော်တို့ indeterminate phase ဆိုတာလည်းရှိတယ်ပေါ့နော်အဲ့ indeterminate phase တွေကိုကြည့်တဲ့အခါမှာကျွန်တော်တို့ကinternational cohort ပေါ့နော် and also ဒီ Taiwanese cohort ကိုကြည့်လိုက်တဲ့အခါမှာလည်းကျွန်တော် 40% of chronic hepatitis B ကဒါ indeterminate phase တွေဖြစ်နေတာပေါ့နော်အဲ့တော့ဒီနောက်ဆုံးထွက်လာတဲ့ဒီ data မှာဆိုလို့ရှိရင်တော့ indeterminate phase တွေကိုဒါကျွန်တော်မကူဘဲနဲ့ treatment မရတဲ့ဒီ phase တွေကဒါ there's a high risk of development of HCC ပေါ့နော်ဒီမှာအသက်45နှစ်ကျော်သွားပြီဆိုလို့ရှိရင်ဒါ 14% ကျွန်တော်14ဆဖြစ်ဖို့ HCC ဖြစ်ဖို့ပိုများတယ်ဆိုတာတွေ့ရတယ်ပေါ့နော်အဲ့တော့နောက်တစ်ခါကျွန်တော်တို့ကဒီtreated နဲ့ untreated ကိုရှင်းလိုက်တဲ့အခါမှာလည်းဟို15 year HCC incident ကကျွန်တော်တို့ treatment မရတဲ့လူတွေမှာဒါပို့ပြီးတော့19% ပိုများတယ်ဆိုတာတွေ့ရတယ်အထူးသဖြင့်တော့ကျွန်တော် subgroup analysis လုပ်တဲ့အခါမှာယောက်ျားတွေအသက်35နှစ်ကျော်ရဲ့ HCC ဖြစ်နိုင်တယ် HBeAg positive hepatitis B DNA ကဒါ1000ကျော်လို့ရှိရင်လည်းဒါ HCC risk များတယ်ဆိုတာဒါကျွန်တော်တို့တွေ့ရတယ်ပေါ့နော်အဲ့တော့ we have been long history of debate ပေါ့နော် or we should treat all ပေါ့နော် or without cirrhosis patient ပေါ့နော်အဲ့တော့ဟိုပြောတဲ့အုပ်စုကဒါ pro အုပ်စုကတော့ဒါ news ပေါ့နော် antiviral တွေက it can prevent the cirrhosis and development of HCC and it is very safe and we have the affordable generic antiviral တွေရှိတယ် and it makes very simple ပေါ့နော် another ဒီကျွန်တော်တို့ဒီဟို con အုပ်စုကတော့ကျွန်တော်တို့ cost effective study တွေမရှိဘူးပေါ့နော်နောက်တစ်ခါကျတော့ adherence issue ဒါရှိနိုင်တယ်ဆိုပြီးတော့တစ်ဖက်ကလည်းဒါထောက်ပြတဲ့အုပ်စုတွေရှိတယ်ပေါ့အဲ့မှာကျွန်တော်တို့ပြန်ကြည့်တဲ့အခါမှာခုနဟိုဆရာကြီးကျော်စိုးလို့ပြောလို့ပဲပေါ့နော်ဟိုဒါ2016လောက်တည်းကစပြီးတော့ WHO ကနေပြီးတော့ဒါ HIV မှာဆိုရင်ဒါ regardless of the clinical status and CD4 count ပေါ့နော် treat all for HIV positive individual ပေါ့နောက်တစ်ခါကျွန်တော် early initiation တော့ antiviral ကိုကြည့်လိုက်တဲ့အခါမှာဒါ ARD စောစောစီးရတဲ့လူတွေကဒါ AIDS ကြောင့်ဖြစ်တဲ့ဒါ complication တွေကိုနည်းစေတယ် non severe non AIDS related condition တွေကလည်းနည်းတယ်ဆိုတာတွေ့ရတယ်ပေါ့နော်ARD စလိုက်ပြီဆိုရင်လည်းဒီ risk တွေကကျန်တယ်ဒါကြောင့်မို့လို့ we need the early initiations of antiviral in HIV population ပေါ့ကျွန်တော်တို့ကဒီ hepatitis B နဲ့ HIV co-infection group ကိုပြန်ပြီးတော့ကြည့်လိုက်တဲ့အခါမှာလည်းဒါ co-infection group တွေက HCC risk နည်းတယ်ဆိုတာတွေ့ရတယ်။ဘာလို့လဲဆိုတော့ HIV ရှိပြီဆိုတော့ hepatitis B ကဒါ tenofovir containing regimen တွေကပါပြီးသားဖြစ်တဲ့အတွက်ဒီလူတွေကအစောကြီး mono infection နဲ့ဆာလိုက်ရင်ဒီလူတွေကအစောကြီးကျွန်တော်တို့က antiviral ရသွားတယ်ပေါ့နော်။ရသွားတဲ့ဒီလူတွေမှာကျွန်တော် HCC risk ကနည်းတယ်ဆိုတာကျွန်တော်တို့တွေ့ရတယ်ပေါ့နော်။ဒါလည်း another study တစ်ခုပေါ့။အဲ့တော့ကျွန်တော်တို့ကဒီ arguments တွေကတော့ကျွန်တော်တို့မှာဒါ highly potent very efficacious antiviral တွေရှိတယ် it can reduce the HCC risk by suppressing the hepatitis B DNA level and reduce the hepatitis B integration ပေါ့နော်စောစောစီးကုမယ်ဆိုရင်ဒါ hepatitis B virus ကကျွန်တော် host ရဲ့ genome ထဲမှာကျွန်တော် integration ဖြစ်တာကိုစောစောစီးသက်သာစေတယ် HCC risk ကိုကျစေတယ်ပေါ့နော်ပြီးတော့ we can prevent the transmission not only horizontal and vertical transmission ပေါ့ဒါကြောင့်မို့လို့ကျွန်တော်တို့က we need a very simplified treatment strategy to drive the hepatitis B WHO elimination goal အဲ့တော့နောက်ပိုင်းနေမှာကျွန်တော်တို့ဒီနောက်ပိုင်းနေမှာဒါကျွန်တော်တို့hepatitis B ကိုစောစောစီးကုဖို့ဆိုတဲ့ဒါကျွန်တော်တို့ data တွေ report တွေဒါထွက်လာကြတယ်ပေါ့နော်ဒီမှာဆိုရင်ဒါကျွန်တော်တို့ very well renowned hepatologist from the current president of AL study ပေါ့နော် Ray Kim ပါမယ်နောက်ကျွန်တော်တို့ဒီ National University of ဒီ Taiwan ဒီ hepatitis B expert တွေကလည်းရေးထားတဲ့ review article အဲ့တော့ကြည့်မယ်ဆိုလို့ရှိရင်ကျွန်တော်တို့က chronic hepatitis B မှာကျွန်တော်တို့ virus ကနေပြီးတော့ host genome ကိုသူက integrate လုပ်သွားတယ် and lead to the insertional mutation and genomic instability and high expressions of the mutant hepatitis B protein and lead to the HCC development အဲ့တော့ကျွန်တော်တို့က not only the cirrhosis ပေါ့နော် chronic hepatitis patient ကလည်း20% လောက်ကလည်းဒါ HCC risk ကိုဖြစ်နိုင်တယ်ပေါ့နော်အဲ့ဒီအရာတွေမှာအကုန်လုံးကဒါကျွန်တော်တို့စောစောစီးစီးကုဖို့ဆိုပြီးတော့ဒါပြောလာကြတယ်ပေါ့အဲ့တော့ hepatitis B DNA integration ကလည်းဒါ all the 4 phases of chronic hepatitis B ပေါ့နော်ဒီမှာဒါကျွန်တော်တို့ရှိတယ်ဆိုတာတွေ့ရတယ်ဒါကြောင့်မို့လို့ကျွန်တော်တို့ဒီ different experts and different group တွေကနေပြီးတော့ we need a very simple guideline earlier treatment initiations and linkage of care ပေါ့နော်2022မှာကျွန်တော်တို့ဒီ China Society ကနေပြီးတော့ဒါ guideline ထွက်လာတယ် China မှာဆိုရင်ဒါ 81% of chronic hepatitis B infected individual တွေရှိတယ်အဲမှာသူက30ကျော်ပေါ့တရုတ်ကတော့30ကျော်ရင်ဒါ detectable DNA level ရှိလားပေါ့ any detectable DNA level yes ဆိုရင်တော့ဒါ treat လုပ်မယ်ပေါ့နော်တကယ်လို့ဟိုအသက်30အောက်ဆိုရင်ဒါ detectable DNA ရှိလားရှိရဆိုရင်တော့ဒါ ALD level upper limit normal ထက်ကျော်ရမယ် F2 fibrosis ရှိရမယ် family history ရှိရမယ် extrahepatic manifestation ရှိရဆိုရင်တော့ဒါ treat လုပ်တယ်ပေါ့နော် cirrhosis ကတော့ဒါ no doubt ပေါ့နော် treat all in cirrhotic individual ပေါ့နောက်တစ်ခု another approach ကတော့ဒါဟိုဒီ US expert group ကလည်းသူကလည်း30ကျော်လား30ကျော်ရင် DNA 2000ကျော်ရင်ဒါကုရမယ်ပေါ့နော်အဲ့တော့30အောက်ဆိုရင်တော့ဒါ DNA 30အောက်ဆိုရင်တော့ DNA ပြန်ကြည့်မယ် ALD ကိုပြန်ကြည့်မယ်ပေါ့နော်ဟိုဘလောက်ပဲ simple လုပ်ပေါ့နော် we need DNA and ALD monitoring for recommending the treatments of hepatitis B infection ပေါ့နောက်တစ်ခုကတော့treat all ပေါ့နော်ဒါ test and treat ပေါ့ like the HIV infections or like the tuberculosis ပေါ့အဲ့တော့ treat all လုပ်မယ်ဆိုလို့ရှိရင်လည်းကျွန်တော်တို့ကဒီရှိတဲ့ဒီ efficacy and safety data တွေကဒါကျွန်တော်တို့က available ဖြစ်တယ်ဒါ very safe ဟိုကျွန်တော်တို့ antiviral တွေရှိတယ်ကျွန်တော်တို့ကဒီ HPV eradication ရဖို့တက်ဆိုလို့ရှိရင်ဒါကျွန်တော်တို့အရင်ဦးဆုံးကတော့စောစောစီးစီးဟို treatment ကိုကျွန်တော်တို့ expand လုပ်ဖို့ပေါ့နော်လူတွေကိုအများကြီးကုနိုင်ဖို့ 80% လောက်ကိုကျွန်တော်တို့ treatment ရဖို့လိုတယ်ပေါ့နော်နောက်တစ်ခုကတော့ကျွန်တော်တို့ treat select ပေါ့နော်ခုနကပြောတဲ့ guideline တွေကိုကျွန်တော်ရွေးပြီးတော့ခုမယ်ဆိုရင်မကောင်းတဲ့ချက်တွေကတော့ we need ဟို6 to 12 month ဒီ hepatitis B DNA လည်းပဲတန်းရမယ် liver function test တွေကိုဆေးရမယ်ပေါ့နော်ဒါတွေဒါကျွန်တော်တို့ဟိုငွေကြေးကုန်ကျစရိတ်တွေရှိနိုင်တယ်ပြီးတော့ဒီလိုမကူဘူးဆိုရင်လူနာမှာ is feel traumatized ဒါဖြစ်နိုင်တယ်ပေါ့နော်ပြီး loss of the self confidence and untreated individual with a higher risk of liver cirrhosis and liver cancer ပေါ့နော်ဒါတွေရှိနိုင်တယ် and there's a risk of transmission ပေါ့နော်ဒါတွေလည်းကျွန်တော်တို့ရှိနိုင်တယ်ပေါ့ဒါရတဲ့ potential treatment expanded ဒီ strategy တွေပေါ့နော် Chinese guideline ရှိတယ်အားလုံးနောက်တစ်ခုကလည်း treat or test and treat all is one of the proposed strategy ပေါ့နော်အဲ့တော့2024မှာကျွန်တော် WHO ကနေပြီးတော့ဒါ guideline အသေးထွက်လာတယ်အဲ့တော့သူရဲ့ guideline ကတော့ကျွန်တော်အဓိက၄ခုပေါ့နော်ခုနအမအမေကြီးပြောသွားတဲ့ every score more than 0.5 ဆိုရင်ဒါ treat လုပ်မယ်fibroscan လုပ်လဲလို့ more than 7 kilopascal F2 test ဆိုရင်ဒါကျွန်တော်တို့ treat လုပ်မယ်ပေါ့နော်အဲ့တော့ DNA စစ်စရာမလို ALD စစ်စရာမလိုအဲ့တော့ every မှာ 0.5 ကျော်သွားရင် fibroscan မှာ7ကျော်သွားရင်ဒါ treat လုပ်မယ်ပေါ့နော်ဒီလိုမဟုတ်ဘူး DNA စစ်နိုင်တယ်ဆိုလဲ DNA စစ်လဲလို့2000ကျော်သွားရင်ဒါကုမယ်ပေါ့နော် ALD upper limit normal ဖြစ်ရင် more than upper limit normal ဖြစ်ရင်ဒါကုမယ်ပေါ့နော်အဲ့တော့ present co-infection HIV HCV ရှိရင်ဒါကုမယ်family history of liver cancer or cirrhosis immunosuppression comorbidity or extrahepatic manifestation regardless of APRI and DNA and ALD level ပေါ့ဒီနောက်တစ်ခုကတော့ DNA level မတိုင်းနိုင်ဘူးဆိုရင်တော့ persistent abnormal ALD လုံးနဲ့လည်းဒါကျွန်တော်တို့ treat လုပ်ရမယ်ဆိုပြီးတော့ WHO ရဲ့ဒါ expanded treatment criteria ဖြစ်ပါဒါတွေကတော့ extrahepatic manifestation ကပါတယ်လေ family history of liver cancer risk ကဒါ chronic ဟိုရှိတယ်ဆိုလို့ရှိရင်ဒါအစား80ဖြစ်ဖို့များတယ်ဆိုတာတွေ့ရတယ်ပေါ့နော်အဲ့တော့ we have very effective antiviral ပေါ့နော်ဒီကောင်တွေက antiviral we can reduce the hepatic inflammation and it can reverse the fibrosis and cirrhosis and prevent the progression to cirrhosis and hepatic decompensation HCC and liver-related mortality ပေါ့နော်ကျွန်တော်တို့ဒါ data တွေအများကြီးရှိပါတယ်အဲ့တော့ it's a very we have long term safety safety data ပေါ့နော်အဲ့တော့ဒီမှာဆိုရင်ဒါကျွန်တော်တို့ကဒါ compare to placebo ပေါ့နော် untreated population နဲ့ treated population ရှင်းလိုက်တဲ့အခါမှာလေ renal failure incidence တွေကနည်းတယ်ဆိုတာတွေ့ရတယ်မကွာဘူးပေါ့နော် renal replacement therapy hip fracture vertebral fracture or fracture ပေါ့ဒါတွေကလည်းဘာမှမကွာဘူးဒါကြောင့်မလို့ is very safe antiviral ပေါ့နော်နောက်တစ်ခါကျွန်တော်တို့က TDF or TAF ပေါ့ကျွန်တော် renal issue မှာတော့ဒါ TF ကပို့ပြီးတော့ renal friendly ပို့ဖြစ်တယ်ဘုံမှာလည်းဒါ fracture risk ကဒါ TF ကပို့ပြီးတော့ favor ပို့ဖြစ်တယ်ပေါ့နော်ဒါတော့နောက်တစ်ခါကျွန်တော် Hong Kong group ကနေပြီးတော့ Chinese University of Hong Kong group ကနေပြီးတော့ဒါဟိုဘေကောင် TDF နဲ့ anti-KVR ရှင်းလိုက်လို့ရှိရင်ပေါ့နော်သူကဒါ20ဟို24 month ပေါ့နှစ်ကျော်ပြီဆိုတာ ਨੇ ဒါကျွန်တော်တို့က TDF group က higher risk of fracture ပေါ့နော်ဒါကြောင့်မလို့အသက်60ကျော်ပြီဆိုလို့ရှိရင်တော့ဒါ renal bone friendly ဖြစ်တဲ့ either anti-KVR or TF ကိုရွေးရမယ်ဆိုတဲ့ဒါ data တစ်ခုပေါ့နော်ဒီမှာကြည့်မယ်ဆိုလို့ရှိရင်လည်းဒါကျွန်တော်တို့96 month မှာဆိုလို့ရှိရင် anti-KVR 6% fracture risk compared to TDF 10.2% fracture risk and then we have ဒီမှာကြည့်မယ်ဆိုကျွန်တော်တို့ဒီ first line antiviral ဖြစ်တဲ့ TDF or anti-KVR ဘာမှတိတ် side effect ကကျွန်တော်တို့မရှိသလောက်ပဲပေါ့နော် and then we have the very good history of the antiviral resistance ပေါ့နော်ကျွန်တော် TDF ကတော့သုံးမယ်ဆိုလို့ရှိရင် more than 5 year ဒါ resistant issue လုံးဝမရှိဘူးပေါ့နော်အဲဒါကြောင့်မလို့ကျွန်တော်တို့ကလူတိုင်းကခုမယ်ဆိုလို့ရှိရင်ပေါ့နော် another issue ကတော့ it can burden on the national health system ပေါ့ဒါရှိနိုင်မလားဆိုပြီးတော့ cost effective ဖြစ်လာပေါ့နောက်ပိုင်းတွေမှာကျွန်တော်တို့ကဟို data တွေကထွက်လာတဲ့ခါမှာ early initiation of antiviral ပေါ့ source ကူတာပို့ပြီးတော့ cost effective ပို့ဖြစ်တယ်ပေါ့နော်လူနာကမကူဘဲနဲ့ဒါ follow up လုပ်ရင်နဲ့ loss ဖြစ်သွားတယ်နောက်တစ်ခုကကျွန်တော်တို့ကဒီ advanced liver disease ဖြစ်တော့မှ like ကူမယ်ဆိုလို့ရှိရင်ပို့ပြီးတော့ကုန်ကျစရိတ်များတယ်ဆိုတော့ဒါ data တွေကျွန်တော်တို့ရှိပါတယ်ဒါမှဆိုရင်ဒါ Lancet ကနေပြီးတော့ publish လုပ်ထားတယ် cost effective ဖြစ်တယ်ဆိုတဲ့ဒါ data တွေ This is one of the cost effective strategy ပေါ့နော်နောက်တစ်ခါကျွန်တော်တို့ကဒီ adherence issue ပေါ့နော်အဲဒီ adherence issue ကိုလည်းကျွန်တော်တို့ကဒီ meta analysis ကိုကြည့်လိုက်တဲ့အခါမှာသူက more than 74% adherence ကောင်းနေဆိုတာတွေ့ရတယ်ပေါ့နော်adherence ကိုကျွန်တော်ဗာနဲ့တိုင်းလဲဆိုတာဒါကျွန်တော်တို့ blood ဟို literature တစ်ခုနဲ့တော့မတူဘူးပေါ့နော် meta analysis ဆိုတာဖြစ်တဲ့အတွက် drug level နဲ့တိုင်းနေဟာတွေရှိတယ်နောက်ကဒါကျွန်တော်တို့ sub report လုပ်တာရှိတယ် electronic medical dispenser တွေကိုကြည့်တယ် adherence case တွေကြည့်တယ် pharmacy claim တွေကိုကြည့်တယ် bill ကောင်ကိုကြည့်တယ်ဒါတွေကြည့်ပြီးတော့ကျွန်တော်တို့ meta analysis လုပ်တဲ့အခါမှာ adherence ကလည်း more than 75% ဆိုတော့ကျွန်တော်တို့တွေ့ရတယ်ပေါ့နော်နောက်တစ်ခါကျွန်တော်တို့က long term ပေါ့နော် antiviral တွေက life long တောက်အောင်မလားပေါ့နောက်ပိုင်းတော့မဟုတ်တော့ပါဘူးကျွန်တော်တို့အခုနောက်ဆုံးဒီ BEPI ပေါ့နော် bepirovirsen ဆိုတာ antisense oligonucleotide ပေါ့နော်သူက injection ထုတ်လိုက်လို့ရှိရင်ဒီမှာဆိုလို့ရှိရင်ကျွန်တော် hepatitis B HBsAg or hepatitis B DNA loss က nearly 10% ပျောက်တယ်ဆိုတော့ကျွန်တော်တွေ့ရတယ်ဒါကြောင့်မလို့ကျွန်တော်က there is a phase 2 B clear study ပေါ့နော်နောက် and then after phase 2 is ongoing B well phase 3 study ပေါ့နော် GSK နေပြီးတော့ဒါ phase 3 trial စပြီးတော့ ongoing လုပ်နေပြီဒါကြောင့်မလို့ကျွန်တော်တို့က maybe we can expect after 3 year ပေါ့နော် we can have this kind of the injection antiviral တွေရနိုင်တယ်ဆိုရင်ဒါကျွန်တော်တို့က life long တောက်ဆရာမလိုတော့ဘူးပေါ့နော်အဲ့တော့ကျွန်တော်ပြန်ပြီးတော့ treat all strategy ကိုဒါကျွန်တော်လုပ်မယ်ဆိုရင်ဘာတွေကောင်းနိုင်လဲပေါ့နော်အဲ့တော့ treat all strategy ကတော့ဒါ functional cure ဖြစ်ဖို့ risk ကတော့နေတယ်ပေါ့နော်ဒါပေမဲ့ we have more than 99% HBV DNA loss က 99% ရနိုင်တယ် we can reverse the fibrosis regression and HCC prevention we can prevent the HCC and we can prevent the cirrhosis development and a negligible amounts of hepatitis B resistant on tenofovir and long-term drug adherence 95% 75% at the 5 year ဒီပြဿနာတခုတော့ကျွန်တော်ရက်လိုက်မယ်ဆိုရင်တော့ဒါ flare ရနိုင်တယ်ပေါ့နော် cost issue အနေနဲ့ကျွန်တော်တို့က we have the very with the affordable price generic တွေရှိရနောက်တော့ side effect ပေါ့နော် side effect ကတော့ဒါ renal or bone ပေါ့ဒါပြဿနာရှိရင်တော့ကျွန်တော်တို့က TF or anti-KVR ဒါရွေးလို့ရတာရှိတယ်ပေါ့နော် and 3 all လုပ်လိုက်တဲ့အခါမှာကျွန်တော် we can prevent the transmission and then is socio-economic ဒါ problem ပေါ့နော်ဒါ discrimination တွေဒါ stigmatization တွေနည်းနိုင်တယ်ပေါ့နော်နောက်တစ်ခါကျွန်တော် real life validated study မရှိဘူးဆိုပြီးတော့ပြောတယ်ပေါ့နော်ဒါပေမဲ့နောက်ခုဒါ recently ပေါ့နော် Uzbekistan is one of the first country to adopt the test and treat all for hepatitis Bပေါ့နော်It's a study show that if there's a feasibility of the large scale general population screening and in low middle income setting ပေါ့ဒါကြောင့်မလို့ကျွန်တော်ဒီ with our Myanmar GI level foundation from all the experts recommended that hepatitis HBsAg positive regardless of the HBV DNA ALT level or fibrosis stage ပေါ့နော် hepatitis HBsAg positive ဖြစ်ပြီဆိုတာ ਨੇ ကျွန်တော်တို့ကတော့ adherence ဟို education တေချာ counseling လုပ်ပြီးရဆိုလို့ရှိရင်တော့ဒါကုရမယ်ပေါ့နော် we recommend လုပ်တယ်တကယ်လို့ဒါမှမကုချင်သေးဘူးဆိုလို့ရှိရင်လည်းပေါ့နော်အဲ့တော့ဟို F2 ရှိပြီဆိုတာ ਨੇ ဒါကုပါပေါ့နော် by means of every 0.5 or fibroscan more than 7 on kilopascal ပေါ့မဟုတ်ဘူးဒါမှလည်းမကုချင်သေးဘူးဆိုရင်တော့ DNA level 6ပေါ့နော် DNA level 6လိုက်လို့ any detectable DNA level ဆိုရင်လည်းဒါကုပါလို့ကျွန်တော်တို့ကပြောတယ်ပေါ့နော်DNA လည်းမစစ်နိုင်ဘူးဆိုရင်ကျွန်တော်တို့ persistent ALT ကိုတိုင်းလိုက် ALT level က persistent abnormal ပေါ့အမျိုးသားတွေဆိုရင် upper limit က30အမျိုးသမီးဆိုရင်19ပေါ့ဒါဆိုရင်လည်းကုပါပေါ့နော်နောက်တစ်ခုကတော့ present present on any following ပေါ့နော် co-infection ရှိရင် Hep C or HIV co-infection ရှိရင်ကုပါ family history of liver cancer liver cirrhosis ရှိရင်ဒါကုရမယ် or immunosuppression ပေါ့ for example steroid ပေါ့နော် prednisolone တောက်နေဆိုင်နေတာကုရမယ်နောက် comorbidity ပေါ့ diabetic mellitus ဒါရှိရင်ကုမယ် extrahepatic manifestation ပေါ့အဲ့တော့ဘာပဲနေနေပေါ့နော်ကျွန်တော်တို့ကတော့ဟိုအားလုံးကုဖို့ပြောတဲ့အခါမှာဒီလူတိုင်းကိုကုဖို့ကြတော့နည်းနည်းလေးဟိုနည်းနည်းတွန့်နေဟိုအချိန်မှာဘာပဲနေနေဒီ9ခုထဲမှာတစ်ခုတော့ဘယ်သူမှတော့မလွတ်နိုင်ဘူးပေါ့နော်ဒါကြောင့်မလို့ so we should treat all hepatitis B infection ပေါ့အဲ့တော့drug of choice ကတော့ကျွန်တော် low genetic barrier to resistance ဖြစ်တဲ့ lamivudine adenophobia tebubudine ဒါတွေကိုကျွန်တော် recommend မလုပ်ဘူးကျွန်တော် recommend လုပ်တာတော့ either TAF or TDF or anti-KVR ပေါ့နော်ဒါကကျွန်တော် first line recommended regimen တွေဖြစ်ပါတယ် TAF or anti-KVR ဘယ်ပို့ပြီးတော့ဦးစားပေးရွေးရမယ်အသက်60ကျော်ရင်chronic steroid use တောင်းနေ or history of bone fracture or osteoporosis and EGFR less than 60 albuminuria or moderate proteinuria and low phosphate or hemodialysis ဆိုရင်တော့ကျွန်တော်ရဲ့ဟို choice ကတော့ TAF or anti-KVR ဖြစ်ပါတယ် Thank you for your attention and I would like to invite Siam Muzoma to present management of chronic hepatitis B in special population.
Good evening, professors and my colleagues and distinguished guests. Today, our working group from University of Medicine Manila will present about the recommendations for chronic hepatitis B infection in special populations. Recommendations for acute hepatitis B infection. Antibiotic treatment with TDF or TAF or anti-KVR is recommended for severe or fulminant form of acute viral hepatitis B. Treatment should be continued until HBs antigen clearance is confirmed or indefinitely in those who undergo liver transplantation. Recommendations for persistent low-level viremia, which is detectable HBV DNA less than 2,000 IU per ml after starting treatment for 48 weeks of ETV or TDF or TAF monotherapy. They should continue monotherapy regardless of the serum ALT. For persons on anti-KVR, TDF or TAF with virological breakthrough, despite the compliance, hepatology referral is recommended. Recommendations about the renal and bone disease in person on nucleoside analog therapy. Consider TAF or anti-KVR in patients with an at-risk for renal dysfunction or bone disease. However, TDF can be used with negligible side effects in patients not at risk for renal dysfunction and bone disease. In case of suspected TDF-associated renal dysfunction and bone disease, TDF should be discontinued and substituted with TAF or anticavir with the consideration for any previously known drug resistance. In patients with impaired renal function, the dosages of nucleoside analog should be adjusted based on creatinine clearance as shown in the table below. TAF is not recommended in patients with creatinine clearance less than 15 ml per minute. And this table is for the reference of choosing nucleoside analogs with recommended doses according to the creatinine clearance. And we have been cited this table from the latest WHO Hepatitis B guideline. Thank you. And the next topic is about the clinical practice guidance recommendation for hepatitis B infection in special population about pregnancy, children, and co-infected patients. So I would like to invite Dr. Nying Mo Yu to present this portion.
Good evening. I will be presenting the topics on special populations in pregnancy, children and adolescents, and in co-infected patients on behalf of the writing group from University of Medicine 2, led by Professor Nainaiton. Mother-to-child transmission is responsible for a majority of hepatitis B in our country and in other Asia-Pacific regions. So prevention of mother-to-child transmission is important in case of prevention of hepatitis B. There will be two parts in prevention of mother-to-child transmission. One is vaccination of infants, and the second one is giving antiviral therapy to the pregnant woman. Vaccination of infants ကတော့ share prevention session မှာပါထားတဲ့ first တွေနဲ့တော့တူတူပါပဲ all infants should receive their first dose of hepatitis B vaccine as soon as possible after birth, as well as hepatitis B immune globulin simultaneously at different sites intramuscularly. And the birth dose should be followed by the subsequent doses to complete the primary prevention series. In case of antiviral therapy, for all pregnant women, hepatitis B surface antigen should be screened in the first trimester. If the mother is not immune or not infected, hepatitis B vaccination should be given in all pregnant women. If the mother is infected with hepatitis B, if they have chronic hepatitis B and advanced fibrosis or cirrhosis, treatment with tenofovir disoproxil fumarate is recommended. In pregnant women already on nucleotide analog therapy, TTF should be continued to reduce the risk of perinatal transmission of hepatitis B. Other nucleotide and nucleoside analogs should be switched to TTF during pregnancy. If the antiviral treatment has already been stopped during first trimester, reassessment should be done to restart the antiviral therapy. For treatment-naive HBsAg positive pregnant women, baseline hepatitis B viral load testing should be done whenever available. If it is not available, our foundation assures that all the HBsAg positive pregnant women receive TTF from second trimester of pregnancy to prevent mother-to-child transmission of hepatitis B if there is no contraindication. The recommendation to continue nucleotide analog after pregnancy is the same as the recommendation for general population. Cesarean section is not recommended to reduce the risk of hepatitis B mother-to-child transmission in HBsAg positive women. Cesarean section may be recommended only in Asian HBeAg positive women with high HBV DNA titer, like more than 7 log 10 copies per mil, who have not received antiviral therapy during pregnancy. Breastfeeding is not prohibited while the mother is on antiviral therapy or infants who receive active or passive immunization. In this table, we describe the antiviral drugs approved for children and adolescents with hepatitis B infection. For children more than 2 years of age, anti-caviar and tenofovir disoproxil fumarate has been recommended. According to the weight-based doses, the tenofovir alafenamide has been recommended in children more than 12 years of age. Regarding the treatment recommendations for hepatitis B in adolescents, it is the same as for adults, but we do not recommend the treat-all strategy in all adolescent patients. We recommend treatment in adolescents with evidence of significant fibrosis more than or equal to F2, a prescore of more than 0.5, or transient elastography value of more than 7 kilopascal, or evidence of cirrhosis based on clinical criteria, or a pre more than 1, or transient elastography value of more than 12.5, regardless of hepatitis B DNA or ALT levels. Hepatitis B DNA more than 2000 and ALT more than upper limit of normal, or presence of co-infections, positive family history, immune suppression, comorbidities, or extrahepatic manifestations. Or if hepatitis B DNA is not done, persistently abnormal ALT levels, regardless of a preschool. A stopping rule is not considered according to the emerging novel drug therapy in the near future, like bepirovirsen. For hepatitis B treatment in children aged 2 to 12 years old, current evidence is not sufficient to support extending the same treatment eligibility criteria. Treatment should be offered on a case-by-case basis, like for children with cirrhosis or advancing liver fibrosis, for children with persistent hepatitis B flare and comorbidities, treatment should be offered. In case of children, when oral antivirals are used, HBeAg seroconversion should be used as a therapeutic endpoint, and treatment should be continued for additional 12 months of consolidation. Children who stop antiviral therapy should be monitored every 3 months for at least 1 year for recurrent viremia, ALT flares, and clinical decompensation. The antiviral drugs recommended for adolescents and children are the same as the adults. Drugs with high genetic barrier are recommended. Anti-caviar for children aged 2 years or older and TF for aged 12 years are recommended for children and adolescents with osteoporosis and impaired kidney function. Another portion is co-infected patients. For hepatitis B and C co-infected patients, hepatitis B DNA level is usually low or absent, and hepatitis C is usually the main driver of infection. They can lead to more severe risks of disease progression than the mono-infected patients. Treatment of hepatitis C with direct-acting antivirus may cause reactivation of hepatitis B, so concomitant hepatitis B treatment should be started in HBsAg positive patients prior to receiving DAA therapy. HBsAg negative anti-HPC positive patients undergoing DAA therapy should be monitored and tested for hepatitis B reactivation in case of ALT elevation. A nucleotide analog treatment is recommended when HBsAg becomes positive. Regarding the hepatitis B and HIV co-infected patients, this co-infection can also lead to more severe disease progression than the mono-infected patients. All HIV positive patients with HPV co-infection should start antiretroviral therapy irrespective of CD4 count and liver status. The ART regime should include 2 drugs with activity against hepatitis B, and they should be treated with a TTF or TF-based ART regime. When TTF and TF cannot be used, anti-caviar should be added to the fully suppressive ART regime. TF may be an option for specific clinical situations in which renal or bone problems are a concern and for adolescents. DTG in combination with NRTI backbone is the preferred first-line drug regimen for patients with hepatitis B and HIV co-infection. Efavirenz at low dose is an alternative to dolutegravir for adults and adolescents. This is the end of my presentation. I would like to invite all the attendees for our Myanmar Hepatology and Gastroenterology Conference at the 7th International Meeting, which will be held on 14 and 15 December 2024. Hepatology မှာလည်း distinguished speaker 26 ယောက်နဲ့ GI မှာတော့ 8 ယောက် distinguished speaker တွေလာမှာမို့လို့အားလုံးလည်း invite လုပ်ချင်ပါတယ်. Thank you for your kind attention.
။ဒီနေ့ကျင်းပပြုလုပ်တဲ့ Hepatitis B Management Guidance Development Launching Meeting ကိုဒီကုန်းချုပ်အမှာစကားပြောကြားပေးပါရန် Professor ဆရာကြီးကျော်စိုးထွန်းအားလေးစားစွာဖိတ်ခေါ်ပါရရှင်။
Hello. Thank you very much, everybody, for your kind attention and your valuable time and your interest in hepatology. Because we can, a handful of hepatologists, we can't treat all the liver diseases in Myanmar. So we need to have a hand from the primary physicians. And thanks for the people for interesting hepatology. As you have already mentioned about the burden of hepatitis B, and also C is also a notorious disease, and its complication, dreaded complications, cirrhosis and HCC is very hard to manage. And then once you contracted it, it's a burden for not only for the patient, the family, society, and for the country also. So I would like to remind you that wherever you find a hepatitis B or C patients, treat as early as possible. Because as long as you wait, the liver damage will be progress, and once they begin to what you call the point of no return, it will be end up in cirrhosis, and the chances of HCC is very high. In a cirrhotic patients, there will be more than 60% chance of having a HCC. So I would like to thank all the speakers for their time and effort on their parts. And then we are very proud to put up this guidance on hepatitis B. And thank you, Siaji. And thank you again, Mylan, for your insightful and for sponsoring this hepatitis guidance booklet. I hope everybody will have a benefit. And whenever you had some queries, you can look back at this guidance book, and then I hope you can manage hepatitis B much better than yesterday. So thank you, everybody, again for your time and kind attention. Thank you, Mylan. Thank you, everybody. Bye.